Thank you so much. Thank you so much for the intro. Like as you said, my name's Fi Mclauchlan, and I'm a practice consultant here with SafeLives. I'm going to be providing a bit of a whistle-stop tour of a project that I've recently been involved in, which is called the REVA project, and that looks at evaluating models of health-based independent domestic violence advisor or advocate provision within maternity services. So it's a bit of a mouthful. But again, just to echo what has been said before, please hold yourselves well with the presentation I'll be doing. And if you need to step out and take a moment for yourselves, I'm not going very deeply into the nuances of domestic abuse, but there's one or two examples. So just want you to hold that with yourselves. So we know that a health IDVA provision is really only an asset to NHS trusts. And health IDVAs are really an integral part of the multi-agency response to domestic abuse, and really are in a great position to provide support to both victim survivors of domestic abuse within a healthcare setting, and also, like has been mentioned before, to staff survivors. When I worked clinically as a safeguarding practitioner in an acute health setting, a fair amount of my caseload was from staff victim survivors of domestic abuse. So providing support to the staff is a large part of health IDVA's role as well. And also very importantly is providing that overview training about domestic abuse, raising domestic abuse awareness to trust staff, and giving very practical support on how to support victim survivors when disclosures come about. So specifically about REVA. So REVA is a study that's actually led by the research team at King's College London, and the project aims to identify learning from NHS trusts that already have a health IDVA programme, and then to evaluate the impact of the implementation activities of the health-based IDVA provision, specifically looking at maternity services. So what's gone really well, what kind of things have the trust been doing to kind of get a health IDVA embedded in the service. And the team's been working with 5 NHS trusts through England, and that's kind of from the north of England to the south, who already have a health IDVA in post. And from some of the data collected, aiming to provide that practical advice on successfully embedding health IDVAs within trusts. So that's an overview of the project in and itself. So how are SafeLives involved? So we at the SafeLives have been able to provide quite specialist support to this study as an independent domestic abuse charity. So we've kind of done that through observing meetings around domestic abuse, health IDVA services in the trust, and trying to support that senior trust level engagement with issues of domestic abuse and the IDVA model, and really importantly, having very open and honest conversations around how the health IDVA model has been embedded, and about how domestic abuse is, how awareness of domestic abuse is raised and within the trusts. And then supporting sites kind of more practically to implement IDVA models in line with some national guidance that we have. So I'd recommend, if you're unaware of the whole health model or the health pathfinder documents and toolkit, I'd really recommend having a look at them. They can be accessed on the SafeLives website. At the end of this, there's a couple of resources that you can have a look through. What we've also done is looked at specific case studies and case reviews of IDVA responses in each site, and then generated conversation and feedback around those cases. We also conducted domestic abuse systems mapping in each area, and this kind of consisted of mapping referral routes and pathways. So how referrals, the pathway kind of went from inpatient acute domestic abuse to like the referral to a community pathway for the patient, for the victim survivor, for the children or the unborn, and then for also, we looked a little bit at perpetrator services, which there's always a very limited amount of sort of nationally, or people who had concerns about their own behaviour within their intimate relationships. And we kind of looked at those to look at identify local areas for improvement. Something really interesting we were able to do within this project, which I think the participants found really helpful, was facilitated a community of practice, which was sort of approximately 6 to 8 weeks over a year, Teams meetings, 2 hours, something like that. And that allowed participants of the study from different trusts to come together, sort of share learning, have a sounding board for barriers within their trusts, celebrate successes and things like that. It was quite interesting because a couple of the times there were spikes in referrals from services sort of from the north of England and the south of England, which we were able to discuss. And also in a couple of the sessions, we were able to provide sort of a brief overview of training from internal SafeLives staff. So Anne-Marie mentioned before non-fatal strangulation. So that had come up in a couple of referrals for the health IDVA across the acute services. So across maternity and across A&E. It wasn't just limited to A&E. So we did a training session around that. We also did a bit of a session around MARAC, so Multi-Agency Risk Assessment Conference, which is a meeting in the community for people at very high risk of domestic abuse, and discuss kind of barriers to that, anything that was kind of going on within MARAC referrals. And also, because of what participants had mentioned in previous sessions, we did a little training on older person domestic abuse. That was something that was coming up in a lot of the community of practices that people felt quite unsure about where to go. So we did a bit of training on that. And then to kind of round it off our involvement, we did a workshop at the end of this project where we focused on celebrating the successes of the health IDVA provision, because not every trust has one. So it is really incredible for the trusts who have one. And then we encourage discussion around barriers and future plans for the service. And this here is just a little graphic that I quite like that shows how kind of this all has been facilitated after a lot of chatting from me. So kind of how the conversations we had, case reviews we looked at and observations kind of came together in the workshop to allow for like a co-created improvement plan and those discussions sort of to be had. So moving on to best practice. So several best practice themes emerged from the work on this project specifically for maternity services that I just wanted to go through, and hopefully you'll find this useful if there's any practical bits that you could take on into your own practice or your own learning. So one I'm going to really bang on about, and Anne-Marie's already kind of touched on it, is routine inquiry questions. So yourselves as midwives, midwifery staff, maternity staff, midwifery students, you're in an incredibly valuable position to respond to domestic abuse. So maternity services, you're really one of the only services where pregnant women are expected to have multiple appointments, sort of attend drop-ins at children's centres, attend outpatient clinics, maybe community midwives, you're going to pop and see women at home. So there's really ample opportunity for routine inquiry about domestic abuse, safety at home questions to be asked each and every appointment, obviously as long as it's safe, and for you to kind of use your professional curiosity to kind of just dig and find out how these women are feeling and are they feeling safe at home. Secondly, I'd really encourage yourselves to ensure you're aware of within your trust of the safeguarding team. If you've got a domestic abuse specialist team, or you may well have a health IDVA within your own trust, and just really make sure that you're aware of how to contact the team, sort of what the referrals pathways are, and then familiarise yourself with them. I know when I was working clinically, the staff I spoke to, you sort of receive a disclosure and there's a certain amount of terror, understandably, and then the feedback I got was them thinking, I've received this now, what on earth do I do with this? It's all on me. And that's very not the case. So receiving disclosure can be very frightening and distressing for yourselves as healthcare practitioners. But it's about being aware of what you can do with that information next. That can be that empowering and confidence building, because we know that yourselves as midwives, midwifery staff, you'll receive disclosures. If you haven't already within your practice, you will. So just really where to seek advice if you have that niggling worry about a patient is really powerful, and allows you to kind of to receive those disclosures. And also if there's a domestic abuse champion within your service that you can talk to, just so you're kind of aware of these people. So when you receive disclosure, you know kind of where you need to be going. next that's come up as best practice in this project is training. I know you're all incredibly busy. I can remember when I was working on the wards, you don't really even have time to go to the toilet, never mind fill out large assessment forms, but really trying to make sure that you can attend all the domestic abuse training that's offered within your trust. And this can be formal stuff. Sometimes there's usually a fair amount about domestic abuse in your level 3 safeguarding training, which I imagine you'll be doing. So it can be formally as part of your CPD, of your NMC revalidation kind of stuff. Or from the project, what we found and what the health advisors I spoke to found most useful is when they were providing that very informal training. So when a staff member, they were walking on maternity and one of the midwives or the maternity assistants came up and said, can I talk to you about something? And then you're kind of getting a group together for that very informal lunchtime kind of training or talking through cases, which they found really beneficial. Also, can you invite a domestic abuse, one of the team or one of the safeguarding team to your morning huddle or handover? Because then you kind of you know who the people are, you know their face, you know you can speak to them, and that, I think, from the people I've spoken to in this project, reduces a bit of that anxiety about making the phone call and that kind of thing. And for those of you that work in the community, could you invite a team member to speak at a team meeting or provide a little bit of training, that kind of thing. And then along those training lines, I'd recommend as well you're aware of the domestic abuse risk assessments that are used within your trust. So the trust that I've worked with, they would often do risk assessment training. So that might be what you'll use in the trust. If you're in Merseyside, it might be the Merit. But it's very likely that your domestic abuse safeguarding team or health advisor, whoever you have in your trust, they're working a 9 to 5, Monday to Friday. That's the whole teams I've been speaking to. That's what they're working. So having an awareness of how to complete the risk assessment that's used within your trust can really increase your confidence in completing these referrals out of hours and that kind of thing. So I said I would go on again. So again, just the case routine inquiry. So that's kind of one of the main takeaways that, if anything, from my talk here is just routine inquiry. So I wanted to keep this slide here. So there's really huge support for normalising these routine inquiry questions on a woman's every attendance to maternity appointment or even on a phone call, if it's safe, inpatient in the community. So an example that we had from the project was one of a lady who was attending maternity services. It was an acute service, so she was coming into the maternity ward almost weekly, and she was reporting pain and reduced fetal movement with her unborn. Every time she was examined, she was well in herself, scanned the baby was well, no problems. And as it turned out, she was actually coming into the department for that feeling of safety and to get out of her house. And because she was pregnant, her abusive partner didn't question these appointments. And even because if she had to do a urine sample, blood sample, you'd usually go in by yourself. And it was really once that she was asked these routine safety at home questions that she then made a disclosure that she was concerned about her partner's behaviour and felt unsafe. And she was able to get the support and these repeated attendances stopped. So I don't know if that rings familiar in anyone listening. And as you can see from this quote here, from a staff participant who we spoke to with this project, a woman who came through our service last year, and she was asked at booking about domestic abuse, and she said, no, everything's fine. But she resolved to tell the next person who asked because she thought, yeah, they want to know. And then no one asked again. So a missed opportunity there to provide support to that person, to that woman and her baby. So the impact of routine inquiry can really be astronomical. A woman may not choose to disclose when the question's initially asked, but feel supported enough that it was even asked in the first place to make a disclosure next time. So it's really important that she has the opportunity to do so. And there's just some quotes here. I won't kind of talk all of them, but a lot of them kind of resonate with what Anne-Marie has said, how the changes in legislation, the changes about from domestic violence to domestic abuse, and it really kind of highlights the impact of training needed. So there's a quote there that domestic abuse is the black eye. If you haven't got a black eye, it must be an argument in the family. And that was said in the Pathfinder consultation. And then something else, my ex-partner was abusive towards me in front of the midwife and nothing was done or said. So these are just kind of little quotes that we have that highlight really the importance of training. And then just one last one that I thought kind of end on a little bit of a brighter note. So I was glad the midwife asked me, you suffer in silence unless you know of services, and I wouldn't have mentioned it. So I was glad she was asked, and that came directly from a survivor talking about her experience in midwifery. And then finally, I've got some resources here where you can find on SafeLives, the Pathfinder toolkit, some information about Whole Health London. And there's also the following article at the top there, which is for more information on the REVA project in and of itself. You can access the article there and about IDVAs in maternity services. So that's available for review now. And that's everything from me. Thank you so much.